Welcome to this explainer. Today we're doing an uncompromising point-by-point breakdown of 8 parenteral hypertension agents, specifically tailored for neurocritical care. Because look, when you're managing acute hypertension in a patient with a vulnerable brain, you don't just need to lower their blood pressure. You need to know exactly how that specific medication is going to impact their intracranial pressure, their heart rate, and their overall cerebral perfusion. Okay, let's dive into our structured roadmap so we can clear up these concepts completely without you ever needing to dig through a textbook again. We've categorized these 8 critical agents into 4 main classes: calcium channel blockers, vasodilators, alpha and beta blockers, and finally, ACE inhibitors. Let's get right into it. Section 1, calcium channel blockers. We'll be looking specifically at nicardipine and clevidipine. Now, these agents are fantastic in the neuro ICU. Why? Well, they generally don't require an arterial line, and crucially, they leave intracranial pressure alone. So the really important point about nicardipine is its specific profile. It's an IV calcium channel blocker that safely avoids spiking your patient's ICP. It doesn't reduce heart rate on its own, but if you do need rate control, you can safely use it right alongside agents like labetalol or esmolol. But here is the massive operational takeaway for your shift. The ampules contain 25 milligrams, and they absolutely must be diluted before administration. You can never, ever push this straight from the ampule. So for dosing, you're typically going to start at 5 milligrams per hour IV. In off-label, highly urgent situations, some providers will jump straight to 10 milligrams per hour. From your starting dose, you titrate up by 2.5 milligrams per hour every 5 to 15 minutes, hitting a hard maximum of 15 milligrams per hour. Once that blood pressure is controlled, you want to drop the rate down to a maintenance dose of around 3 milligrams per hour. But keep a really sharp eye out for side effects here. Headaches are incredibly common, hitting about 15% of patients. You also have a 5% chance of nausea or hypotension and a 3.5% chance of reflex tachycardia. Let's switch gears to clevidipine and see how this builds. It's also an IVCCB, but its mechanism is highly selective for vascular smooth muscle. It reduces mean arterial pressure by dropping the systemic vascular resistance. And what's really beautiful about clevidipine is that it's rapidly degraded by esterases in the blood and extravascular tissues, meaning its metabolism is completely independent of the liver or kidneys. You literally need 0 dose adjustments for patients with liver or renal insufficiency. It's a huge advantage. This brilliantly illustrates the key operational difference between the two. While nicardipine has to be diluted, clevidipine is a completely different story. It actually comes as a lipid emulsion. It's got this milky white appearance that looks very much like propofol, which honestly can cause some major confusion if you aren't paying attention. It is not diluted before administration. Just remember, because it's a lipid, it can induce hypertriglyceridemia if you aren't actively tracking their overall lipid load. And because of that exact lipid loading issue we just talked about, you've got a hard ceiling. You absolutely must limit clevidipine infusions to less than or equal to 1,000 milliliters per 24 hours. If you do the math on that, it averages out to a maximum continuous run of about 21 milligrams per hour. Now, the titration speed for clevidipine is lightning fast. You start at 1 to 2 milligrams per hour IV. Then you literally double the dose every 90 seconds until you're nearing your desired blood pressure target. Once you get close, you back off, making much smaller increments, maxing out at 32 milligrams per hour. Though honestly, in practice, control is usually achieved at 16 milligrams per hour or less. Perioperative data shows you can get a 4 to 5% drop in systolic blood pressure within just minutes. Section 2, vasodilators. For this group, we're focusing on nitroglycerin and phenyldopam. Entering vasodilator territory means we have to be incredibly mindful about hazardous impacts on intracranial pressure. Unlike our calcium channel blockers, nitroglycerin does raise ICP. Now, it raises it less than nitroprusside does, but it's still a very real concern for a neuro patient. It works via preferential venous vasodilation over arterial. This effectively decreases left ventricular filling pressure or preload. A major benefit to remember here is that it doesn't cause coronary steal, meaning it won't dangerously divert blood away from ischemic areas of the heart. Here we map out the exact dosing. For an NTG IV drip, you're running 10 to 20 micrograms per minute, and you're stepping that up by 5 to 10 micrograms every 5 to 10 minutes. If you happen to be treating angina pectoris, you're looking at 0.4 milligrams sublingually, up to 3 times. Now, contrast this with phenyldopam. Phenyldopam acts in less than 5 minutes. You start the drip at 0.1 to 0.3 micrograms per kilogram per minute, and titrate up by 0.1 every 15 minutes to a maximum of 1.6. And please note the emphatic rule here. Absolutely no bolus doses for phenyldopam. None. Section 3, alpha and beta blockers. Let's dig into labetalol, esmolol, and propranolol. With this versatile group, monitoring cardiac output, knowing their airway history, and checking heart rate becomes absolutely paramount before you administer a single drop. Let's start with labetalol. It's a heavy hitter. It blocks selective alpha-1 and non-selective beta receptors. For our neurofocus, it safely reduces or maintains ICP, and it does this without exacerbating coronary ischemia or changing the patient's cardiac output. But remember, the crucial point is that it's strictly contraindicated in patients with asthma or overt congestive heart failure. Interestingly enough, renal failure patients get the exact same dose. Just watch out for fatigue, dizziness, and orthostatic hypotension as that pressure drops. Okay, let's dive into this highly specific labetalol IV push sequence. You really can't just push this randomly. First, the patient must be supine, and you need to check their blood pressure every 5 minutes. You administer each dose as a slow IV push over 2 minutes, spaced every 10 minutes. The sequence itself is rigid. You give 20 milligrams, then 40, then 80, then 80, and a final 80. That caps you out at a 300 milligram total limit. Once they're controlled, your maintenance dose is roughly the same total dose given every 8 hours. If you're running a continuous drip or converting a patient to oral, the mixtures are highly specific. For the drip, you add 200 milligrams to 160 milliliters of IV fluid, using a 1 milligram per milliliter concentration, which you run at 2 milliliters a minute. For oral conversion, keep in mind it undergoes massive first-pass liver degradation. Because the liver chews up so much of it right away, oral doses need to be significantly higher. You actually start with 200 milligrams orally twice a day, and you can push that all the way up to a max of 2,400 milligrams a day. Next up is esmol, a cardioselective short-acting beta blocker. Esmol is truly fascinating because it's metabolized by red blood cell esterases. This gives it an ultra-short elimination half-life of just 9 minutes. Think about how fast that is. While bronchospasm is less likely here than with other beta blockers, you still need to avoid it in CHF. The major side effect is dose-related hypotension, which hits up to 50% of patients. But thankfully, because of that rapid 9-minute half-life, the hypotension usually resolves within 30 minutes of just stopping the drug. So the crucial takeaway for esmolol is this unique loading and infusion cycle. Step 1, you hit them with a 500 microgram per kilogram loading dose over 1 minute. Step 2, follow that immediately with a 4-minute infusion at 50 micrograms per kilogram per minute. Step 3, if you need more blood pressure control, you repeat that loading dose and bump the infusion rate by another 50 every 5 minutes. But definitely take note of this. Pushing doses above 200 micrograms per kilogram per minute rarely adds any clinical benefit at all. Lastly, for our beta blockers, we have propranolol. In the acute neurocritical setting, propranolol is mainly used IV to counteract the reflex tachycardia caused by other vasodilators. You wouldn't typically use it acutely to lower the blood pressure entirely on its own. You load with 1 to 10 milligrams as a slow IV push, followed by a 3 milligram per hour drip. If you're transitioning them to oral, the dose ranges anywhere from 80 to 640 milligrams daily in divided doses. Section 4, ACE inhibitors. For this final group, we're focusing exclusively on enalaprilat. Enalaprilat is actually the active metabolite of the oral drug enalapril. When you give it IV, it acts rapidly, getting to work within about 15 minutes of administration. There are 2 absolute things to lock into your memory here. First, it is absolutely contraindicated during pregnancy. Never use it for a pregnant patient. Second, it carries a very real risk of hyperkalemia, which occurs in about 1% of patients, so you absolutely must monitor those potassium levels. Dosing for enalaprilat is incredibly straightforward, especially when you compare it to the escalating steps of labetalol or that rapid doubling of clofazepine we just talked about. You simply start with a 1.25 milligram slow IV push over 5 minutes. If that isn't cutting it, you can bump the dose up to 5 milligrams, given every 6 hours as needed. Clean, simple, and effective. We've covered a massive amount of textbook detail today, dissecting the precise onset times, the exact dilution rules, and the vital ICP interactions of these drugs. From the esterase metabolism of clofazepine to the rigid dosing sequence of labetalol, you now have the visual blueprints right in front of you. So, I leave you with this question. With these 8 distinct tools now fully mapped out and understood, which profile will you instinctively reach for on your next shift to best protect your patient's brain? Thanks for joining me on this explainer. Keep learning, keep pushing, and I'll see you next time.